Hi, this is me from Physios Academia, and in this video we would learn about carpal tunnel syndrome. So let's jump straight in carpal tunnel syndrome. Carpal tunnel syndrome is caused by compression of the median nerve as it travels through the carpal tunnel in the wrist, causing pain and numbness on the distribution of median nerve in the hand. Let's just start with the anatomy and basic pathophysiology. The flexor retiniculum is a fibrous band that wraps around the front on the palmar side of the wrist. It is also known as transverse carpal ligament. Between the carpal bones and flexor retiniculum, there is a passageway from the forearm to the hand, and which is called the carpal tunnel. The median nerve and the 9 flexors. See the median nerve and the flexor tendons, the 9 flexor tendons that pass way through the carpal tunnel, and that's why the compression of the contents of the carpal tunnel causing the carpal tunnel syndrome. It's the result of either swallowing of the contents, for example swelling of the tendon sheets due repetitive strain, or narrowing of the tunnel. The branch of the median nerve that passes through the carpal tunnel is called the palmar digital cutaneous branch and is responsible for sensory innervation of the palmar aspect and the full fingertips of the thumb, index and the middle finger. It's worth noting that the palmar cutaneous branch of the median nerve provides sensation to the palm. However, this branch originates before the carpal tunnel and it doesn't travel through the carpal tunnel. Before, it's not affected by carpal tunnel syndrome. Therefore, it's not affected by carpal tunnel syndrome. The median nerve also supplies the motor function to the 3 ethnoid muscles, and these 3 ethnoid muscles make up the muscular bulge at the base of the thumb and is responsible for thumb movements. The abductor pollicis brevis causes the thumb abduction. The opponent's pollicis causing thumb opposition, and thumb opposition is where the thumb reaches across the palm of the hands to touch the tips of the fingers. The flexor pollicis brevis, which is responsible for thumb flexion. The other muscles that controls thumb movements is the abductor pollicis, and which causes the thumb adduction. This muscle is innervated by the ulnar nerve. Whether it's classed as one of the thinner muscles depends on you where you look. Risk factors in most cases of the carpal tunnel syndrome, that is idiopathic, meaning there is no clear cause that can be found. There is a number of key risk factors including repetitive strain, obesity being perimenopause, rheumatoid arthritis, diabetes, acromegaly, in hypothyroidism, and in the end the pregnancy. So the top tip for you, the link between bilateral carpal tunnel syndrome and acromegaly came up several times in my clinical experience. Cases were present with a patient with symptoms of bilateral carpal tunnel syndrome, and the challenge was not only to diagnose carpal tunnel syndrome but also to identify the underlying cause. Whenever you see a patient that has a diagnosis like that, ask yourself whether that diagnosis might have an underlying cause and look for the features of that cause. For example, if you see a patient with bilateral carpal tunnel syndrome, look for features that might suggest underlying rheumatoid arthritis, diabetes, acromegaly, or hypothyroidism. Going this extra step will take you from average exam scores to the very top schools. So let's talk about the presentation. Carpal tunnel syndrome usually has a gradual onset of symptoms. Initially, the symptoms are intermittent, often they're worse at night. Carpal tunnel syndrome causes sensory symptoms in the distribution of palmar digital cutaneous branch of the median nerve, affecting the palmar aspects and full fingertips to the thumb, index and middle finger, and the later half of the ring finger. Now, the sensory symptoms include numbness, paresthesia, which is pins and needles, then tingling, a burning sensation, or pain. Patients often find sensory symptoms are worse at night. The symptoms may cause to wake up from the sleep, and they may describe it shaking their hands to try to and relieve the symptoms. The motor symptoms of the carpal tunnel syndrome affects the thenar muscles at the base of the thumb, with weakness of thumb movements, difficulty with grip strength, and fine movements involving the thumb, and the wasting of the thenar muscles, where there is muscles atrophy at the base of the thumb. So let's talk about these special tests. There are two special tests to remember for the carpal tunnel syndrome. Number one is Phelan's test, and number is the Tunnel's test. The Phelan's test is spelled with the P, which involves fully flexing the wrist and holding it at this position. Often this is done by asking the patient to put the backs of their hand together in front of them with their wrists bent inward at 90 degrees. The test is positive when this position triggers the sensory symptoms of the carpal tunnel syndrome, with numbness in paresthesia and the median nerve distribution. Tunnel test tapping the wrist at the location where the median nerve travels through the carpal tunnel, and this is in the middle of the point. The test is positive when the sensory symptoms of the carpal tunnel syndrome triggers with the numbness and paresthesia in the median nerve distribution. A top tip for you to remember which way around tunnels and phalanx is I remember tapping a tin can for tunnel test. After discussing the special tests, now next talk about the carpal tunnel questionnaire. The Camuthand Stoddard Carpal Tunnel Questionnaire gives a score based on the symptoms of the carpal tunnel, and it can be used to predict the likelihood of the diagnosis of carpal tunnel syndrome. A high score in the questionnaire may replace the need for nerve conduction studies confirm the diagnosis. The score is based on the questions such as: do the symptoms wake you of the night? Do you have special movements, for example, shaking the hand to improve the symptoms? And is your little finger affected? Answering yes to whether the little finger affected scores negatively, making carpal tunnel syndrome less likely. Let's talk about the nerve conduction studies. Nerve conduction studies are the primary investigations for establishing the diagnosis. A small electrical current is applied by an electrode or nerve stimulator to the median nerve on one side of the carpal tunnel. Recording electrodes over the median nerve on the other side of the carpal tunnel syndrome record the electrical current and that reaches them, and this demonstrates how well the signals passing through the carpal tunnel along the median nerve. Let's finally talk about the management. Management options for carpal tunnel syndrome are rest and altered activity. Rest splints, then maintain a neutral position of the wrist, one at the night time, typically for a minimum of 4 weeks, steroid injections, and surgery. Carpal tunnel surgery is usually performed as a day case procedure under a local anesthetic, and it can be performed by open surgery with reverse convection as the rest by endoscopic or keyhole surgery. The flexor retinaculum, which is also known as the transverse carpal ligament, is to cut and release the pressure on the median nerve. So let's go for the treatments of carpal tunnel syndrome. One major form of treatment is behavior modification, and many of which are associated with hand positions while typing, which is a common cause of the problem. Changes like keeping the hands parallel to each other and the table, using a computer mouse instead of trackpad, and wearing wrist supports and splints while typing will be super helpful. Physical therapy in the form of stretching and isometric exercises, it also help relieving symptoms. Thank you.